I'd like to introduce Ed Nardell, our last Sloan Keynote speaker. Dr. Nardell is an associate professor of medicine at Harvard Medical School with parallel appointments in the departments of environmental health, immunology, and infectious disease at Harvard School of Public Health. Dr. Nardell collaborated with Richard Riley for an 18-year period. Together, they published many of the seminal papers on tuberculosis transmission and UV disinfection. We're pleased to have him speak here. Please welcome Professor Edward Nardell.
Thank you very much. I really am grateful to be here. It's my first indoor air meeting. It won't be my last. I did come to Healthy Buildings about 17 years ago, and I have learned a lot at this meeting, and I certainly intend to try to participate. I want to thank Charlie Weschler, Al Levin, Hugo Lee, and the Sloan Foundation for making this possible. I am a physician, as Julian is as well, and I think it's important to have the interdisciplinary approach. I'm going to be talking to you about some environmental interventions around airborne infection control, particularly tuberculosis. But before I get there, I really need to talk to you to some degree about where those interventions need to be and a little bit more about source control, as you'll see. Let's see. No. Okay, thank you. So, brief quote to start with. Again, as a physician, one of the environments that is important to discuss is the hospital, particularly although transmission occurs of airborne infection in many environments. The hospital is a particularly important one, and it's not a new problem. This quote, a fragment of space enclosed on itself, a placement of internment of men in disease, it's ceremonious but inept architecture multiplying the ills of its interior without preventing their outward diffusion. The hospital is more of a center of death for the cities where it is sited than a therapeutic agent for the population as a whole. And I think for many centuries that was the case, and it was really with the insights, not of an engineer, not of a physician, but of this remarkable nurse, Florence Nightingale, who during the Crimean War saw the state of hospitals at that time and the spread of infection long before antibiotics, and resolved to do something about it, and in Notes on Hospitals details the distance between beds, comments on ventilation, did not have the advantage of all the data that you see presented here, but had an awful lot of common sense. And you see at the bottom a illustration of a Nightingale ward with beds lined up, as many as a nurse at that time was expected to care for, and still we have this configuration with ideally cross-ventilation with its benefits and problems. Person-to-person airborne infection, I would submit, is one of the world's most major building-associated illnesses, tuberculosis infection in particular. I would say the most important, but I hesitate to say that here because there are so many problems associated with indoor air and outdoor air. But TB and HIV are the two leading causes of adult infectious deaths in the world still, and most HIV patients globally die of tuberculosis. So, when you put those together, it is a huge problem. Most transmission occurs indoors, certainly in homes. I would submit that's rather difficult to intervene in terms of environmental interventions. But in congregate settings like hospitals and clinics, prisons and jails, homeless shelters, residential facilities, it's certainly possible. Transportation, as we've just heard, is another issue, a lot more difficult to intervene, but nonetheless, places where transmission occurs. The situation from the 17th and 18th centuries has improved in many places of the world, but in other places of the world it has not. Here you have a crowded waiting area. We've seen pictures of this. In one of the places where my organization, Partners in Health, works is in Tomsk, Siberia. And we did a study some time ago there that showed We thought that the risk for MDR-TB was going to be primarily for patients who didn't take their medication, alcoholic, but it turned out that you were 6 times more likely to develop MDR-TB if you were admitted to the hospital than if you were not admitted to the hospital for regular TB. Another dramatic outbreak was in KwaZulu-Natal, South Africa, where 53 XDR patients were first recognized as extensively drug-resistant TB, and of course they had the same genetic strain. Most of them had not been previously treated for TB. This was all transmitted TB on what, again, looks like a Nightingale ward with plenty of windows, but nonetheless, transmission occurred. Now, much of we know of airborne transmission from a more scientific perspective rather than epidemiologic perspective. It really comes from these 2 gentlemen. What you're seeing is Richard Riley holding the photo of William Firth Wells. I took that picture in Richard's home in Petersham, Massachusetts, about 3 or 4 years before he died at age 90. And for the last 18 years of his life, we had a chance to work together. And here depicted is the famous experiment that he did, where patients, 6 beds, were occupied by TB patients who were admitted and thought to be infectious. And in the penthouse above were hundreds of guinea pigs, were quite susceptible, breathing the air. And the reason this was necessary is you can't culture tuberculosis out of the air. And so if you really want to know how much is transmitted, you need a biological system. And so this is human to guinea pig transmission studies. And you can find an article reproduced in more recent literature, because a lot of these articles are old enough, they're hard to find. You'll be interested to know the Wells-Riley equation has been cited many times at this meeting. And Richard Riley is not the Riley of the Wells-Riley equation. It's his brother Ed, who was an engineer. And it was Ed who worked with William Firth Wells and got Richard a job with Wells when he was a medical student at Harvard. So the lessons we learned from Wells and Riley go back to the droplet nuclei concept itself. In Wells's book, he attributes that to Richard Riley. TB as an airborne infection was not proven until this late period, even though that Koch had discovered the organism quite some time ago. But when you consider we still don't know how flu is transmitted very convincingly, I guess that is a progress, not a problem. We do know that TB is predominantly airborne. The studies he did showed that there was great variability in infectiousness, and I put it down as the 10-90 rule. It could be the 20-80 rule, but the point is that very few patients account for most transmission. There is no such thing as an average infectiousness of many infectious diseases, but tuberculosis in particular. Over 4 years of using that experimental ward, Riley quantified the infectious doses, which he called quanta, and I should have converted this to metric, and I intended to, but I forgot. So 1 in 11,000 cubic feet of air over that period of time. That's incredibly dilute. Forget about multiple hits and things like that under those conditions, but it was enough to explain the rate at which student nurses became infected working on wards in the pre-chemotherapy era. So probability plays an enormous role in tuberculosis, and for that reason, the models that you see talking about are involve biostatistics, because this is a probabilistic event. Now, I heard several people say, oh, it takes a long time to become infected with tuberculosis. The infection with tuberculosis is an instantaneous event, almost. You inhale an organism that infects a macrophage, which is why it's airborne. It has to get deep into the lung. That happens very quickly. It may take a long time for you statistically to inhale that organism that finds the macrophage that's going to be infected. It's not multiple hits causing infection, it's a single event. Why? How do we know that? Children who get primary TB don't get multiple foci, they get a single focus of infection. So, and the last thing I want to mention, which is, move on from this, is that therapy, he showed, was profoundly effective in stopping transmission, and that's quite relevant to this group. And I know you're not involved in therapy, but I'll tell you why that's important. So if we want to look at the propagation of tuberculosis, we have the source strength, and Wells-Riley equation can tell you, with all of its assumptions, that this could range from as little as 1 an hour to perhaps as many as 250. Organisms are in the air, they reach a host, there's host resistance. You have to get down to the alveolar level, and then you progress from infection to the disease, cavities with 10 to the 8th organisms in these cavities, and we go round and round. Now let's look at this in a bit more detail. Many factors, room volume, ventilation. There's evidence now that in the airborne state, perhaps organisms become somewhat spore-like. There's the effects on these organisms in the air. We know almost nothing about the aerobiology of TB or most infectious diseases other than those involved in germ warfare. The treatment effect I've mentioned, and of course that's counterbalanced by drug resistance. We have to deal with the virulence factor. And the last of this series is to throw in some interventions here. We know we can inhibit, and I gave a figure at one of the conferences here. We have data that suggests that a mask reduces the number of particles generated, a surgical mask on patients with TB, by about 50%, not more, not less, in that study. Treatment, I'll show you, is profoundly effective, and these come into administrative controls, isolation as well. If we unsuccessful here, we move on to environmental controls such as ventilation, filtration, and UVGI. And then, of course, there are vaccines, and the vaccines are thought to, in some cases, prevent infection, and of course, respiratory protection in terms of a respirator. And if people are infected, we can give treatment for latent infection to interrupt this cycle. Julian just already showed this, and I'll show it again for tuberculosis in particular. So we're talking about, I've put it slightly different, administrative controls as source controls. So building design and use, separation, isolation, crowding, population density, surgical masks on patients, again, about 50% effective in our studies. Effective treatment, highly effective. Environmental controls, we're going to focus on that, and respiratory protection I'm not going to touch on. So this is the data from Riley's study. And in the first 2 years, there was quite a bit of variability in month to month in the terms of the number of guinea pigs that were infected by the patients in the ward to the guinea pigs in the penthouse. And so in the second 2 years, the era before IRBs, they actually did not treat some patients for a while, and the other patients they treated, and drug-resistant patients the same. And if you consider, based on the amount of time on the ward, that the 61 patients who infected 29 guinea pigs were 100%, treated patients were 2% as infectious, or 98% reduction due to treatment. What I missed in the first 50 times that I read this paper was that this effect was almost immediate. Patients were not treated until they entered the ward. And they didn't become sputum negative, their cultures were still positive, but once they were on therapy, they were no longer infectious, almost immediately. The effect is less profound with drug resistance, and in the quote, which I won't share with you, Riley says, "It's just not enough data here to be sure," but I'll tell you more about that as we go along. How does that happen? I'm not so sure we know. The Loudon, back in the 60s, thought maybe the antibiotic that's in the secretions as the droplets evaporate and become airborne, that drug concentration must skyrocket and become very high, just like the solutes and the salts and the solutions that Bill Nazaroff was referring to. These are not naked organisms. They're organisms that are contained in respiratory secretions. And as respiratory secretions evaporate, perhaps that's a factor. I think there could be other stresses on the organism that affect some processes and transcription, et cetera, and not others, and that you can easily have growth in culture, in sputum, and not have transmission through the air. So I had a chance earlier in the week to participate in a TB infection control course here in Hong Kong, And our colleagues here in Hong Kong are very proud of the fact that there's very little transmission to healthcare workers here, and they attribute it to isolation. I would say that if you're identifying patients and have them on treatment, it has nothing to do with isolation. Those patients you don't have to worry about. They're on treatment. It's the patients we don't know about who are in the hospital, who are not being treated, that are the problem. And all of our attention, we love isolation rooms. We love to think about negative pressure. It has nothing to do with protecting patients from tuberculosis transmission because they're on therapy, hopefully. Okay, for maybe a few hours while you're figuring out what's going on. But basically, what's happened now is that we have rapid diagnostics. In another era, we wouldn't know that people had drug-resistant TB for months. We can know that in 2 hours. There is no reason to have people on the wrong therapy. But most of TB infection control revolves around this and not effective therapy. So this is the problem. Unsuspected untreated TB, I won't go into the details, but in one study in Peru, there was a third of the patients who were proven to have TB were unsuspected. I just got a paper from South Africa, almost the same number. So if you go to a general medical ward in an endemic area, people will be there for other things who have infectious TB, and they're not known. In the meantime, somebody's in isolation who is not infectious at all, and that's where the attention goes. If it's a TB hospital and everybody is known to have TB or suspected, it's the unsuspected drug-resistant cases. And that's what Riley found, that the patients who were transmitted were the drug-resistant ones initially. And then he realized that and did the second year, 2-year study. So if everybody has TB, it's the unsuspected drug-resistant cases. What about MDR-TB? So we've reestablished the Riley ward. Richard and I talked about this for years before he died. I mean, it's almost 10 years now. Collaboration with CDC and our collaborators in South Africa. And it's an MDR-TB hospital. We have 6 patient beds. We don't have a penthouse. It's a 1-story building, but we have an adjacent area here, which the patients are not aware of, and I mean, they of course agree to be in the study, where we have the guinea pig cages on 2 sides here. And you'll see why there are 2 chambers. Lots of people have been involved, many sources of funding, particularly NIOSH, was interested in protecting healthcare workers or workers in general from respiratory infection. So I don't have time to go in a great deal of this, but what this represents are several experiments, and what you're looking here is control arms of these experiments where there were no interventions. There were no masks on patients, there was no UV. This is just straight transmission of 26 patients over 4 months to, in this case, 360 guinea pigs. 74% of them become infected. 24 patients over 3 months, only 10% infected. 15 patients over 2 months, all by the same criteria: smear positive, cavitary, coughing, recently started on therapy. 15 patients, 2 months, 53. Then this experiment, which was a total failure from studying interventions, we had 27 patients with these criteria over 3 months, and 1 guinea pig was infected in that facility. We're scratching our head, and then look back again at Riley's studies. They had the same problem, and it had all to do with treatment. So what was going on? We recovered organisms from the guinea pigs. The ones that transmitted didn't have MDR-TB. They had XDR-TB. They weren't being treated. And this experiment, where there was no transmission essentially, there was no XDR-TB. All of those patients' transmission was being suppressed by standard South African multi-drug resistant TB therapy. So it seems consistent. Treatment, effective treatment stops transmission. So in an MDR hospital, such as this, the patients who are available to transmit are those that have unsuspected XDR-TB, because they're not being treated. Now, as I mentioned, in the era of rapid diagnostics, we can diagnose TB quickly. There's no reason to have people enter into a facility. We've turned this concept into an approach, an administrative approach called FAST, find cases actively, cough surveillance. Rapid diagnosis by molecular means, separate temporarily to reduce exposure, and treat effectively based on rapid DST. And this is being implemented in many parts of the world. It is strictly administrative controls. There are things you can measure, like time from cough surveillance to detection, and to starting therapy, et cetera. In a hospital like in Zambia, there might be a ward where you could do cough surveillance, have a nearby gene expert machine. There is no reason for people to be entering the building who have unsuspected TB. And there are some building design and engineering aspects to doing this approach as well. Now, do buildings matter? They do. And here's some data from Peru. The rate at which medical students at Cayetano Hospital convert their skin tests from negative to positive. Despite BCG, most are negative at the beginning, and by the end of 7 years, the rate goes to almost 46%. Interestingly, these medical students were assigned to one of two hospitals, and the rate was very different. There are twice as many conversions of those assigned to the Cayetano Hospital than those went to the Loaiza Hospital. Interestingly, the volume, and you can see the difference in design. This is a more modern building with a ventilation system, doesn't work very well. This is a older French-style hospital with big windows open and a volume per person, per bed, that is about twice as great as that. And the rate of, this is the one where the rate of conversion was half of what it was there. Observational, but it's hard to find data that suggests that the building matters, and this is, I think, some of it. Now, what about crowding? And I apologize for the crudeness of this slide compared to some of the things we've seen. I should have things moving. But at any rate, the concept was just simple. We all know that crowding makes a difference, but if we have 100 people in one place and there's a 2% risk of an infectious case, 98 people are exposed. There's a higher percentage that those people are going to be there. If we divide that up into 10 smaller units, I've only shown 2, the cases occupy 2 of them, you end up with an 82% risk reduction just by redistributing people in smaller entities. Now, we teach a course at Harvard. We're not doing it this year, but we've done 6 years of building design and engineering approaches to airborne infection control, 2 weeks in the summer, and we've trained about over 200 engineers and architects. This is the first course, and I show this slide for a couple reasons. To acknowledge a few people, Paul Jensen, who has been a colleague in this work, an engineer with a microbiology PhD, and Mel First, who co-founded this course with me, and who has trained many of the people at this building and interested them in environmental engineering and microbiology as well. And Tariq and his hospital administrator from Pakistan, who attended the first course 6 years ago, on the plane home tore up their plans for the hospital, and within a year had plans for a naturally ventilated building. It became architectural drawings, and within a year was an actual hospital in Karachi with outdoor waiting and designed for natural ventilation. And the question is, does the design work? And one of the questions we've asked in a 5-year Fogarty program we have is to try and get at how do we know this building is better than that building? It looks nice, it follows principles, we can measure instantaneous ventilation, natural ventilation, but what does that mean in terms of people's exposure? We have some ideas of how to do this, but we don't have the answer yet. But it's an important question. So we all know that natural ventilation, it's been mentioned as well, has its limits. Windows are not always open. I work in Siberia, you can't open them at all for much of the year. There are issues about cold at night, even in Africa, vermin, safety. So it's a question. And so, you know, when you think about that, and this morning at the plenary, what was mentioned was mechanical ventilation, natural ventilation, and filtration. Left off the docket is an important tool of germicidal UV, and the rest of the time, which is not much, I'm going to devote to this topic. We did start a few minutes late, but anyway. Highly effective, highly cost-effective, I've shown you, but it's an orphan technology. It's not owned by engineers, it's not owned by architects, and it's not owned by lighting people. So it hasn't developed. Compared to the development that has happened in control systems, in mechanical systems, if we had that kind of attention, we'd be in a very different place. We've been making very slow but real progress in this area. Now, it applies to other infections, and this is an old observational study from 57 to 58 in Livermore, VA, where there was a 95% reduction in influenza in wards that happened to have UV because they were TB wards compared to the wards that did not have UV. And again, not a planned study, observational, but suggestive that number one, influenza in this case was airborne, and number two, that UV was effective in stopping it. So where should it be used? Again, going to put this in the isolation room? No, patients are on therapy, they're not infectious. You want to put this in general medical areas, in waiting areas, et cetera, where there is a risk of TB. Old technology, this book by Lukish is 1946, again, has not received the attention it deserves. 2009, however, NIOSH put out a document, excellent review of the literature to that point, but has some problems, as you'll see. Now, this was based largely on Shelly Miller's study funded by NIOSH, which was a very good study and showed a great deal of efficacy, and this was the parameters they came up with: 30 to 50 microwatts average irradiance in a plane in the upper room, and or 6.3 total UV watts per cubic meter of room volume in the upper room. But the problem is that when you talk about UV watts or even the watts that go into the fixture, it doesn't deal with fixture efficacy, and you'll see why it's important. The data that we base our dosing on up till now has been Riley's original work, a different study, not with guinea pigs, where this was the disappearance rate of aerosolized BCG without any UV on, and here it is with a single lamp on, and it happened to be a 17-watt bulb. It produced the equivalent of 10 air changes, and they argued that if you put 30 watts in, maybe you'd get 20 air changes per 200 square feet of floor space, and that's been the rule we had. Rod Escom in Peru did a study with guinea pigs and showed 72% efficacy. I think that would be closer to 80 if you adjusted for multiple hits, as we have done. So it's a very similar result that I'll show you. So going back to our facility, we tested germicidal UV in the upper room, paddle fan, air coming in here, going in there. We had an interesting study design. The air went every other day to this guinea pig colony or that guinea pig colony, and the UV lights were on every other day. This is also how we did the mask study. The mask patients would wear masks every other day. The air would go one guinea pig colony or the other, depending on the day. Well, here it is with UV, and here are the results. So there were a total of 48 infections in the control days versus 15 in the intervention days. This is a hazard ratio of 4.9, approximately 80% effectiveness, adding the equivalent of 24 mechanical air changes in terms of air disinfection, the equivalent of 24 mechanical air changes. So we think that this is the basis for a good basis for a better dosing schedule, and we have now the advantage of a CAD package, which a computer-assisted design. Here is a fixture. It's hard to see on this wall and over here, and these clouds are irradiance zones that the computerized program generates for us and helps us to know how much UV we had in the room. To do that, you need to know the output of the fixture, which requires gonioradiometry, something that we wouldn't do as a user, but the company should do before they sell you the fixture. Or if you don't care about the distribution, you can use an integrating sphere to tell you how much UV is coming out of that fixture. And if I don't get much further than this, this is fine. Back in
2 more minutes.
2007, Steve Rudnick and Mel First published a paper on the fundamental factors of what makes UV work. So you have to have a fixture and you have to have a certain fluence rate, and if you do it if you assume there's good mixing in the room, the number you're really interested in is how much irradiance you're putting into that room volume. You don't need to know its distribution, particularly with one exception here. The distribution issue is this. The UV only works until it hits a wall and gets absorbed. So if you put a fixture on this long wall, you get much more effect than if you put it on the short wall. So we want long ray length as much as possible. And the third thing we need is air mixing. And a paddle fan does it. It isn't critical whether it's up or down. It isn't even critical what the velocity is, and for reasons I could go into. So skip that slide here. We had this Riley study with 200 square feet of area. We have NIOSH guidelines, which are hard to predict because in advance of doing the actual installation. We're now going to tell you that if you put 4 to 5 microwatts average UV using the visual UV program, you could do that. But a practical guideline is just provide 17 milliwatts per cubic meter and use the longest ray lengths you can. There's a problem with not having adequate fixtures that are well designed. We're having a meeting in Pretoria next week on international standards. Turns out the fixtures we use varied by 10 times in efficiency. And so I asked the question, is there a better way to do this? And I was at this airport and had an aha moment, and we decided that instead of baffling the UV at the fixture, we could baffle it at the ceiling level and use a perforated egg crate ceiling. And when we do that, we get, and these are our chamber studies of how we've tested this, we get, and published this in Indoor Air, we get dramatic increases in equivalent air changes. This is the egg crate versus conventional, 1 lamp, 2 lamps, talking 60 equivalent air changes by just using the egg crate UV approach. The last thing, this is some data from Paul Jensen and Grigory Volchenkov showing that if ventilation is a cost-effectiveness issue of 1, these are several air cleaners, UVGI, upper room UVGI, using pretty primitive fixtures was 9 times more efficient. And then finally, just wanted to mention LED UV, which is coming along. It's still too expensive and not reliable enough, but in the future, I think we'll be putting little clusters of UV LED lights above an egg crate ceiling. And the advantage of this is that this works on low current, could run on a battery, could run on solar power, and is really ideal for developing country use. So, last slide. I'd make the point that it's much more important to identify the unsuspected case and get rid of the source, and we have an administrative way to get at that. UV technology underused, highly effective. We need to get the dosing strategies and the fixtures right. The egg crate system works really well, and LED is promising. I think India and China particularly require a lot of work to introduce this technology in a technically good way, and it may be relevant also to pandemic influenza preparation. And I'll stop there. Thank you.
Thank you very much, Dr. Nardell, for giving your perspectives on this huge public health topic and your fascinating insights into isolation rooms, and also describing your current work on the still famous guinea pig experiment.
I think that concludes the session. That there isn't any announcement from the organizer, then we will be done for this. Thank you for attending the session and all the speakers.
呢個執咩啊？冇用。呢個係咪你哋㗎？係啊係啊。冇用啊？呢個壞壞地。係。唔夠電定係壞壞地？呢個又呢個就呢個壞壞地。哦，你哋嗰個壞壞地。呢個就係你。